This was a topic that was requested after last year's conference. In our previous 5-minute discussion, we talked about the primary consequence of critical illness being shock. Now we're going to dive into the principal result of shock and one controversial management strategy. So like Morpheus, I'm going to ask you to take either the blue pill or the red pill. The blue pill will send you back to the clinical practice of old, the one that may or may not have proven results for you. The red pill will remove you from that comfort zone and move you more towards current evidence. Take this critically ill patient lying in bed with the following blood gas. If you subscribe to the method that I use in reading these, you already know everything you need with the first two values. This is a metabolic acidosis. And in examining the following set of electrolytes, you have additional perspective on how best to manage. So how would you manage it? My guess is that your answer is a big box of IV baking soda. For all intents and purposes, not a bad option, as it will most certainly increase pH, but will it help? Remember that a byproduct of normal cellular respiration, which is aerobic metabolism, is carbon dioxide. Carbon dioxide combines with water in the blood to form carbonic acid. This dissociates into hydrogen ions and bicarbonate ions for ease of regulation by the kidneys. This situation is typically in a state of equilibrium, meaning that all components coexist at all times and that an increase in one component will cause a shift of the equation in the opposite direction. This is an attempt to maintain that state of equilibrium. So, based upon this, and with your knowledge of what affects pH, you can see what happens when you add more baking soda to this recipe. And since we talked about respiratory regulation of acid-base balance in the last lecture, let's quickly review the kidney's role in this, albeit a much slower process. In the kidneys, blood pH is controlled by excretion of hydrogen ions and reabsorption of bicarbonate. This occurs mainly at the proximal tubule. Remember that this process is much slower than the respiratory response, hours to days versus minutes to hours. So then what should be our threshold for adding more sodium bicarbonate to the blood? Based upon everything that I have read over the years, everyone can agree that severe metabolic acidosis, which usually is a blood pH of less than 7.2, is associated with impaired hemodynamics, increased mortality in the critically ill. But this is pretty much where that agreement stops. The latest moderately sized randomized controlled trial conducted in France last year enrolled close to 400 patients, and its conclusions were that the administration of sodium bicarbonate to profoundly acidotic and hemodynamically unstable patients had no effect on overall mortality or 28-day ICU or hospital discharge rates. You can read this study on your own, but that was pretty much the Cliff Notes version of it. So again, when is it appropriate to give bicarb from a physiologic standpoint? Non-anion gap metabolic acidosis is a clear-cut bicarb deficiency. This could be from hyperchloremia, from massive crystalloid resuscitation, or prolonged hyperalimentation or TPN therapy, or could be from absolute bicarb loss from excessive vomiting and diarrhea. Giving bicarb in this situation makes sense. If the patient's illness isn't compounded by kidney disease, bicarbonate will eventually be regenerated on its own, but like we discussed earlier, this can take days. If a patient is acidotic secondary to uremia, this can actually cause a widened anion gap. We could treat this with bicarb to 1. Manage the acidosis, and 2. Treat hyperkalemia associated with kidney injury. Ketoacidosis, especially DKA, doesn't benefit from bicarb therapy. In fact, it's the last medication that we want to consider in this instance, as the hypertonicity of bicarb alone contributes to cerebral edema in these patients. The most effective approach is to treat ketoacidosis itself. Acidosis in this instance is managed with volume and insulin. A widened anion gap with a high lactate doesn't benefit from bicarbonate therapy either. Again, treat the cause. So let's say after all of this, it's most sincerely time to give bicarb. How should we do it? Convention tells us to rip the box apart, put the big syringe together, and push like you've never pushed before. And this is where once again convention has let us down. It turns out that from a physiologic perspective, if you are looking to actually make a difference in the patient's acid-base balance and serum potassium level, a more isotonic preparation has the most effect. So, It is true that increasing pH shifts potassium into cells and thereby improves hyperkalemia, which is why bicarb is a therapy for hyperkalemia in the first place. Not the primary, but one nonetheless. Bicarbonate in the big box is strongly hypertonic, with a saline concentration of close to 6%. Remember that administration of hypertonic fluids pulls water out of the cells, which pulls potassium out along with it. This can actually increase serum potassium level. Large volumes of potassium-free fluid can decrease the potassium level just by dilution alone. This effect comes into play when giving a pretty good volume of isotonic bicarbonate. So now let's get back to our patient example. Does any of what we have talked about in the last few minutes change your management strategy? He has a widened anion gap metabolic acidosis, and I think that it's safe to say that this is from a high lactate. Certainly at or around 4, I would think. This guy would more than likely benefit from increased oxygen delivery with enhancement of cardiac output. We'll save that topic for another day. Before we wrap it up, I just wanted to quickly cover good old bicarb and the management of cardiac arrest. While to my knowledge it still hasn't made its way mainstream into the ACLS algorithms, it is still being given like candy pre and in hospital to those patients suffering from cardiac arrest. While I'm not going to provide any better insight, I will give you a snapshot of why this is still quite controversial from an evidence standpoint. It's because that while some suggest it does have an effect on return of spontaneous circulation, it has no effect on neurologic outcome and hospital discharge, which to my knowledge is still what the AHA standards are written for.